Morning, everyone. So I've been asked to do a presentation on drugs in the kidney. So um, obviously this is a picture of the kidney showing you the gross anatomy of the kidney. Obviously, looking at the kidney, the functional units are usually always in the cortex of the kidney. This is a nephron, which is a very simplistic view of the nephron. What's missing in this picture is obviously the supporting structure, the interstitium. And I think that will become apparent later why that interstitium is so important. Obviously, a multitude of drugs, different forms, different ways of administering it. I'm sure you've spoken to patients and they always tell you that they take a blue, orange, yellow, or square or round pill. Um, Drugs obviously administered intravenously, intramuscularly, and orally. So, as an overview, we're looking at the renal physiology and pharmacokinetics, the drugs in the normal kidney, drugs toxic to the kidney, prescribing in kidney disease, and looking at normal kidney function. It's got an extracellular fluid volume control, critic controls electrolyte balance, and waste product excretion. Um, there's obviously drug and hormone elimination metabolism, blood pressure regulation, regulation of hematocrit, regulation of calcium phosphate metabolism, and vitamin D3 metabolism. Now, the clinical estimation of renal function is important when you're administering drugs. Obviously, your clinical examination is important, whether your patient's got pallor, volume status, blood pressure measurement is important. Urine analysis might help you, especially in prescribing chronic medication, and sometimes in the acute setting, well, most times in the acute setting as well. Blood tests, of course, do actually give you an idea what your kidney function is. Routine tests, hemoglobin levels, electrolyte measurements, potassium, sodium, calcium phosphate, urea, and creatinine, which is normally between 70 to 140 micromoles per liter. Serum creatinine and GFR don't always correlate, so they don't always match together. So if you look at creatinine, which is the muscle metabolite, concentration is proportional to your muscle mass. So a highly muscular young man might have um, a higher creatinine, whereas in conditions with muscle wasting, the elderly, muscular dystrophy, anorexia, malignancy, you might have actually falsely low creatinine. So normal range is 70 to 140 micromoles. GFR estimation, which is usually used in the chronic setting, not in the acute setting. It's a progression of chronic renal disease. Historically, we used to use the Cockcroft-Gault formula, which was a bedside formula, and obviously became controversial when using a factor, whether the patient is black, female, male, those kind of things. Example, if you got a patient with a creatinine of 85 or 95, very small patient, its creatinine clearance actually might work up to 33 mils per minute, but knowing that your creatinine actually is in a normal range. The MDRD formula obviously is given to us by the labs routinely, but for other reasons, it doesn't always translate into a true reflection of the patient's kidney function. So, test for renal function. Um, Previously, in the past, 24-hour urine sample for creatinine clearance, um, chromium EDTA clearance, which is a bit more accurate, but the gold standard is actually inulin clearance. Pharmacokinetics of the kidney, multiple functions, absorption, distribution, metabolism, elimination, filtration, secretion. So looking at drugs and electrolytes, sorry about the spelling, but looking at the ones commonly used, diuretics, loop, thiazides, aldosterone antagonists, and osmotic diuretics. The indications for use for diuretics, heart failure, pulmonary edema, hypertension, nephrotic syndrome, hypercalcemia, hypercalciuria. Loop diuretics, typically we use one furosemide or Lasix. Its indication is overload, hypertension, hypercalcemia. The mechanism of action, and looking back at the nephron, so it's a blockade of the sodium potassium to chloride co-transporter in the thick ascending loop of Henle. Its oral bioavailability between 10 and 19 minutes. It acts on the luminal side of the thick ascending limb. It's highly protein bound, and you get a rebound after a single dose. Half-life is about 4 hours. The caution in using the loop diuretics is obviously the electrolyte imbalances, hypokalemia, volume depletion, pre-renal uremia, tinnitus. So patients can become deaf on Lasix, and especially when you're using it well in combination with your aminoglycoside antibiotics. The thiazide diuretics, which are bendrafluozine, metolazone. The site of action is the distal convoluted tubule. It blocks electroneutral sodium chloride exchanger. It reduces the site of action, reaches the site of action in a glomerular filtrate. High doses required in GFRs, in low GFRs. It's ineffective when the creatinine is greater than 200 micromoles. Half-life is about 3 to 5 hours. It should be the standard prescribed drug for first-line therapy for hypertension, often not. Its indication is antihypertensive, especially in combination with ACE inhibitors or your angiotensin receptor blockers. In combination with loop diuretics for profound edema. The cautions, it causes metabolic side effects, hyperuricemia, impaired glucose tolerance, electrolyte disturbances, hypokalemia, and hyponatremia, and volume depletion. Not very often used amiloride, but certainly spironolactone is used more often. The amiloride blocks the ENSA channel for sodium secretion in the collecting duct under aldosterone control. Spironolactone, which is the aldosterone receptor antagonist, which reaches the distal convoluted tubule via the bloodstream. It's not dependent on GFR. Often combined with loop or thiazides to capitalize on the potassium-sparing action. Spironolactone as a class, it's a potassium-sparing diuretic. It's a mode of action. It antagonizes the action of aldactone at levels MR, so that's your mineral corticoid receptor, aldosterone complex, and translocates to the nucleus to affect gene transcription. It prevents hypokalemia in patients taking diuretics or digoxin, improves survival in advanced heart failure. So that was the Rails study, which was done in 1999. As an hypertensive, it's an adjunct third-line therapy for hypertension or first line for Conn's patients. Of course, it's used for patients with ascites and cirrhosis. Side effects, androgenic effects through the antagonism of DHT or testosterone and its binding sites at its binding site. So it causes gynecomastia, impotence, reduced libido. Interactions often patient potassium sparing drugs, example ACE inhibitors, ARBs, potassium supplements. Remember, low salt use is the sodium chloride substitute in cooking, which actually has got potassium in it, as well as a bit of sodium. Just touch on drugs that actually are toxic when you got a reduced kidney function. Looking at digoxin, it's so you got a high level demonstrated in 10 and toxicity reported in 4 of a series of 4,000 digoxin samples. Kinetics, it's a large volume distribution. A reservoir is skeletal muscle. About 30% of stores excreted in the urine per day. Just to touch on the treatment of digoxin toxicity, it's usually supportive. It corrects the electrolyte imbalances, so especially the hypokalemia, atropine for bradycardia, and avoid cardiac stimulants because they're arrhythmogenic. So you can limit the absorption of digoxin by using charcoal effective within 8 hours or cholestyramine. Specific measures, digibind, FAP, digitoxin-specific antibodies, binds plasma digoxin complex, and eliminated by the kidneys. Used within ODs is the high near rest. And enhanced elimination. Dialysis is ineffective in digoxin, so your charcoal cholestyramine interrupts the intrahepatic circulation or cycling. So exposure to medication and drugs on a regular basis. Most are well tolerated. Subgroup develop adverse renal effects. Your hospitalized patients greater than your R patients. Drugs are associated with AKI in 14 to 26% of adults in prospective cohort studies. Drug-induced injury is at the tubular interstitial component is common as a cause of AKI. So when we mentioned the nephron, we looked at the nephron structure, and I said that the part that was missing was actually the supporting structure, which is the interstitial. So that's a very important part of the function unit. So the common nephrotoxic drugs are your therapeutic agents, your alternative products, and diagnostic agents, and of course, every environmental exposure. And the therapeutic agents used in our setting and in the hospital setting, obviously, is your antimicrobials, your chemotherapy drugs, special attention to your analgesics, your COX inhibitors. In our setting, nephrology, your immunosuppressives such as your calcium channel, calcium inhibitors, sirolimus. Of course, the over-the-counter medication as well can actually cause toxicity, especially important there. And obviously, most often than not, your COX inhibitors are actually prescribed over the counter. So looking at your nephrotoxic risk factors, patient-specific, it depends on your true or effective volume depletion. So obviously, most of our patients are a bit on the dry side because they're in a hospital and don't often get their fluids for various reasons. Obviously, the immune response is also important. So you get depending on what the patient's immune response genes are like, and your pharmacokinetics favoring drug toxicity. So depending on your renal transporters, loss, depending on the function of your cytochrome P450 enzymes and so forth. Also, your other patient factors, which probably are important, is your age of your patient. If the patient has got coexisting nephrotic syndrome, cirrhosis, if your patient is an acute on chronic kidney disease, and there are other multiple mechanisms, reasons why patients have risk factors for nephrotoxicity. Kidney specific, so there's obviously the kidney receives about 20 to 25% of your cardiac output. So you get an increased toxin concentration in your renal medulla and interstitium. There's biotransformation of substances to reactive oxygen species. There's a high metabolic rate in the tubular cells and leukophilin. And obviously, depending on your apical and bio-basal transport systems as well. Drug-specific reasons for nephrotoxicity include things like prolonged dosing regimens, periods, and toxin exposure. Well, drug is actually directly nephrotoxic. On the compound, a combination of toxins, drugs, so prescribing drugs together, and obviously, depending on whether your drug is lipophilic, hydrophilic, and what kind of absorption these characteristics it has. So classification of drug-induced nephropathies, we can classify them as pseudo-AKI, AKI, which would include basically your pre-renal, intrarenal, post-renal tubulopathys, and CKD. Intrarenal, we can further break that down into what we look at your microanatomy of your nephron, which includes your glomerular injury, your tubules, your vasculature, and your interstitium. So that's 4 components of your nephron. Pseudo-AKI, so it's when patients present with an increased creatinine, and some of those drugs that contribute to that are things like cimetidine, trimethoprim, flucytosine. Your corticosteroids can do it because patients have a catabolic state with increased release of creatinine from muscle, which is converted to creatinine. There are your fibrates, which actually also contribute to an increased creatinine, and some of the other agents do like calcitrol, and then say vitamin D. The mechanism is actually unclear. Pre-renal acute renal failure. So the mechanisms associated with hemodynamically mediated AKI. So it will be your angiotensin converting enzyme inhibitors, which obviously your NSAIDs, your SGLT2 inhibitors, and your calcineurin inhibitors. What is common among all these drugs is that they induce a vasoconstriction of your efferent arteriole of your drums and thereby reduce blood flow to the kidneys. So that's the mechanism why they cause an acute pre-renal failure. Intrinsic AKI, we look at drugs that induce vascular injury. So your drugs that can induce a thrombotic microangiopathy, various chemotherapeutic drugs, including radiation therapy, mitomycin and cisplatin. Drugs that can also cause a vasculitis. So drugs like hydralazine, allopurinol, which commonly is used in our setting, and of course drugs that can cause cholesterol emboli, thrombolytic agents, heparin, warfarin. So, and also the drugs that cause an acute glomerulitis, so either a nephrotic kind of syndrome. And the various drugs include your antibiotics like penicillin, quinolones, causing minimal change disease, COX-2 inhibitors, and your COX-2 inhibitors as well. So even though your COX-2 inhibitors might be safe in certain settings, they're certainly not safe for the kidney. FSGS, or focal segmental glomerulosclerosis, can be caused by drugs like lithium, heroin, and of course your membranous glomerulitis, like gold, captopril, penicillamine. So those are some of the drugs that actually can contribute to an intrinsic AKI. So with intrinsic AKI, obviously you get a tubular injury. So your modifiable risk factors for those things are probably obviously volume depletion, exposure to multiple nephrotoxins, and high exposure, long exposure of the drugs. Non-modifiable risk factors obviously include your age of your patient, what's your underlying chronic kidney disease status, obviously shock status such as sepsis, solid organ transplantation, stem cells transplantation, and of course there's a genetic vulnerability for these patients to having tubular injury from certain treatment drugs. So this is a photo of acute tubular injury, and you can see the tubular cells with simplification. So they actually undergone acute tubular necrosis. So drugs-induced tubular necrosis includes your antibiotics, antifungal agents, your main agents now setting are, of course, your aminoglycosides, the cephalosporins, vancomycin. Chemotherapeutic agents which can be involved in tubular injury include drugs like methotrexate, which are commonly used as well as cisplatin, contrast media, so your hyperosmolar contrast media, obviously versus your isoosmolar contrast media, which is less nephrotoxic. Miscellaneous drugs, statins, warfarin, cocaine, amphetamine, and bath salts. So intrinsic AKI, the proximal tubular injury, so the apical drug transport mechanisms. So taking a typical example like aminoglycosides, you get an uptake of aminoglycosides by the proximal tubule by an initial binding to metgallin. So obviously the aminoglycoside molecule gets into the tubular cell and fuses with the lysosomes. And obviously once inside, you get induces cellular injury through multiple mechanisms. An example of a basolateral uh, drug transport that actually causes proximal tubular injury is tenofovir, and also by a similar kind of mechanism, TDF can cause cellular injury when it accumulates in cells, often targeting the mitochondrion. So, like I mentioned, the other miscellaneous drugs like statins, which are amphibrates, which can cause muscle injury during release of myoglobin. Myoglobin is nephrotoxic by a variety of mechanisms, including vasoconstriction of renal blood vessels, tubule obstruction by cast formation, direct proximal tubular cell injury. So the treatment of rhabdomyolysis includes aggressive intravascular volume repletion to maintain a high urine output rates and to prevent precipitation of myoglobin. Also looking at radio contrast media angiography, the mechanism of direct tubular injury is thought to be multifactorial. Oxidative stress from increased production of free oxygen radicals, osmotic cellular injury. So it's highest with your higher osmolar contrast, hemodynamics, so you're getting ischemic component to it, so the reduction of renal blood flow. Your renal, obviously, your risk factors is pre-existing CKD, let's say your GFR less than 60, diabetes, volume depletion, congestive heart failure, older age, patients on taking nephrotoxic drugs at that moment, especially your NSAIDs, but I probably would include your ACE inhibitors, your ARBs in this group as well. And obviously, if your patient's anemic and so on. The preventive measures, very controversial, but at the moment, as things stand, it says optimize your flow volume status. Okay, and of course, use of low volume and isoosmolar contrast is advocated. Warfarin, which is commonly used in our setting and obviously a regular drug that's prescribed by lots. So toxicity described patients with and without CKD who are over anticoagulated. The cause of the AKI is not clearly known, but may be related to glomerular hemorrhage, tubule obstruction, and heme-related tubular injury from lysosomal overload and oxidative damage. The therapy is reversal of the anticoagulation initially, followed by more judicious anticoagulation in those who are truly required. Most patients do not recover and they go into CKD. So this photograph shows you a patient who is on warfarin. Obviously, you can see the glomerular hemorrhage. So it's known as warfarin nephropathy, and it causes in the setting of over anticoagulation in a patient with underlying kidney disease, such as IgA nephropathy. Your preventive strategies for causing acute tubular injury include, so when you look at antibiotics, obviously prescribing your antibiotics is important. And what's been shown is that, especially when it comes to things like aminoglycosides, once daily dosing is actually optimum recommended therapy with drug levels. Sometimes increasing the interval between dosing might actually be important and actually help prevent toxicity. With your antifungals, using the lysosomal form of amphotericin B might help in reducing the risk of amphotericin. Of course, in patients with drugs like tenofovir or some of your other antiviral agents, your ARVs. You can look at using alternative agents or something like, and like I mentioned in the previous slides, that your GFR, although doesn't always translate to normal kidney function, neither does your creatinine. So in these kind of patients, doing a simple test like a urine dipsticks to see whether these patients got protein in the urine might actually guide you whether you should prescribe drugs like tenofovir and some of your antivirals in these patients. Your analgesics, whether they actually, you can avoid them, use an alternative form of analgesics to obviously avoid the anti-inflammatories in elderly patients with radio contrast media. Look at alternative ways of actually imaging the patient, and of course trying to avoid the hyperosmolar contrast media. Just to mention bisphosphonates. Bisphosphonates should be used when absolutely necessary. Sometimes increasing the reducing the dose actually might help in preventing nephrotoxicity. Crystal nephropathies caused by many drugs. Some of them actually commonly used drugs, such as your methotrexate, ciprofloxacin, nitrofurantoin, and this is micrograph showing a patient with crystals in the kidney. From Eden therapy, the insoluble ileum crystals can precipitate within the distal tubular lumen and cause a kidney injury. Other drugs such as acyclovir, sulfadiazine, ciprofloxacin, and acylivir may also cause crystal nephropathy. So this is a diagram showing you how the crystals actually get from the urine into the tubular cell, and they might actually go on via TNF to dendritic cells, causing a intrarenal inflammation, and also into the cells via TNF receptor, also causing necroptosis, also with an immune reaction causing vascular permeability, vasodilatation, and complement activation, and therefore causing an interstitial pyelonephritis. The number of drugs that can cause crystal nephropathy, including drugs like methotrexate. There, obviously, we mentioned your antiretroviral therapies, other antiviral agents, your commonly used antibiotics like ciprofloxacin, which can cause crystaluria and AKI. And of course, you have to look at preventive and therapeutic strategies. So avoiding, for instance, in patients with acyclovir, avoid rapid IV boluses, adjust drug doses for kidney function, and obviously ensure a euvolemia during the drug therapy. So an acute interstitial nephritis, miscellaneous associated with acute interstitial nephritis or other medication involved with acute interstitial nephritis. So your antibiotics, your beta-lactams, which obviously your penicillins and your cephalosporins, your sulfur-based antimicrobials, your antacid GIT drugs, so your proton inhibitors, and your antiviral agents, like I mentioned, acyclovir, inivir, abacavir. Anticonvulsants also can cause an acute interstitial nephritis, such as phenytoin and carbamazepine. Other agents, lithium allopurinol, also should be carefully prescribed when patients got underlying chronic kidney disease. So with an acute interstitial nephritis, the diagram on your left-hand side, which shows you obviously entry of the drug into your tubular cell, causing an immune response that can actually cause activation of your eosinophils and macrophages and your CD8 T cells. And the diagram on your right shows you the acute interstitial nephritis. And many drugs can cause acute interstitial nephritis. So it's a cellular interstitial infiltrate involving lymphocytes, eosinophils, and polymorphic nuclear cells, plasma cells. The diagnosis of acute interstitial nephritis, the hallmark of classic AIN is rapid onset of AKI after the initiation of a suspect drug. The time course between exposure and the onset of renal injury is important, it's generally within 2 weeks. Prior exposure to an agent may result in more rapid onset. So, importantly, NSAIDs and PPIs may take many months. Beta-lactams and sulfur antibiotics classically induce a systemic response, including fever, rash, and peripheral eosinophilia. But other drugs associated with AIN do not commonly elicit these signs, so you actually get a slow, prolonged slide of your kidney function. Hypersensitivity reactions in the kidney is typified by AKI, low-grade proteinuria, hematuria, and a sterile kind of pyuria. Management withdrawal of the causative agent obviously may be difficult to pinpoint in the hospitalized patients because patients are receiving multiple medications. So you might have a stepwise withdrawal of agents beginning with the most common offending agent. Corticosteroid therapy may help in the acute setting, given the acute inflammatory nature of the AIN. There is no randomized controlled trials to support the use. It may be beneficial with faster renal recovery, fewer instances of CKD, but better when given either in the disease course, earlier in the disease course, sorry. Post-renal AKI, which is your obstructive cardiomyopathies, which can happen at any when part of the kidney. So examples would be your retroperitoneal fibrosis from beta blockers, your methotrexate, which is used for your migraine headaches, drugs that can cause nephrolithiasis, so your antibacterials, including ciprofloxacin, nitrofurantoin protease inhibitors, and drugs that can cause urinary retention, so your opiates, your anticholinergics, typically like your trepoline, and obviously your muscle relaxants as well. So any drug that results in a prolonged or repeated AKI theoretically puts a particular patient at risk for chronic kidney disease and even dialysis dependent. Certain agents, however, result in CKD over time without causing acute disturbances in renal function. So drug-induced chronic kidney disease, lithium is a typical example that actually might, if not monitored judiciously, might actually result in a patient having developing chronic kidney disease in the future. Lithium toxicity, lithium carbonate for the treatment of bipolar affective disorder, toxicity closely related to serum levels. Your symptoms are arrhythmias, CNS is tremor, confusion, and coma. Treatment is supportive, hemodialysis, and colonic irrigation for severe cases. Inadvertent intoxication from interaction with ACE inhibitors, loop diuretics, thiazide diuretics, and carbamazepine and other antiepileptic drugs will increase their neurotoxicity. Prescribing in chronic kidney disease, failure to properly adjust medication in patients diagnosed with varying stages of CKD may result in adverse drug reactions. An estimated 40% of patients with CKD receive excessive doses of medication. There is positive association with the number of medications and higher mortality rates in patients with CKD or chronic kidney disease. It's important to identify patients with CKD, estimating renal function and adjusting the drug dosage appropriately according to renal function. The principles of altered pharmacokinetics in CKD. So absorption is actually mostly unchanged as far as your pharmacokinetics is concerned, but your distribution of your drug may be increased, especially if your drug is hydrophilic. Your protein binding is decreased when the patient got reduced kidney function. Metabolism is definitely decreased, and elimination is decreased. So the effect on the pharmacokinetics of the drugs in your chronic kidney disease obviously contribute to a greater toxicity of your drug. Dosing regimens in chronic kidney disease. So when your patient's got when the drug has got a wide therapeutic index indication, no adjustment is needed. So short duration of therapy, less than 3 to 7 days, such as fluconazole for candidiasis. Low or prophylactic dosing, such as trimethoprim, which is Bactrim. AKI is likely reversible due to decreased perfusion, such as antibiotics for septic shock. So adjustments are needed when the accumulation associated with drugs such as cefepime encephalopathy. When a drug has got a narrow therapeutic index, there is no adjustment needed, especially in your loading dose. The patient-specific first dose or loading dose, such as warfarin, theophylline, phenobarbital. The adjustment is needed in all maintenance dosages, such as all renally eliminated medication. Dosing by therapeutic drug monitoring, such as aminoglycosides, phenytoin, lithium, and digoxin. So when we're prescribing a drug in with kidney disease, with significant renal excretion is prescribed. In renal impairment, the dosing regimen can be adjusted in 3 ways. You can reduce the dose or extend the dosing interval or combination of both. Dose adjustment is normally only required when the creatinine clearance is less than 60 moles per minute. People who have been taking a drug for many years may need a dose adjustment as they age. Prescribing specific drugs in CKD, beta-lactams, accumulation is significantly increased. The risk of seizures when high doses are used in patients with renal impairment. Acyclovir dose-related side effects, higher risk in elderly patients and those taking other neurotoxic drugs. Lower doses are necessary when GFR is less than 50 mL per minute. Opiate analgesics prolong effects in renal failure because of accumulation of the parent drug and some active metabolites. Use cautiously with dose reduction and increased dosing interval. ACE inhibitors and ARBs needed to be used with caution because of the risks of hyperkalemia and renal function decline. Those at greatest risk of toxicity, obviously the elderly patient, and obviously the concomitant use of other high-risk drugs like your anti-inflammatories, spironolactone loop diuretics. Patients with diabetes, increased risk of renal artery stenosis. So a checkup of your renal function is required after 3 to 4 days and again 7 to 10 days following introduction, dose titration, or introduction of another interacting drug. Potassium-sparing diuretics and potassium supplements are more likely to cause significant hyperkalemia, should be avoided. Digoxin accumulation, even in mild degrees of renal impairment, necessitating reduced dose. Haloperidol and its active principal metabolites, oxypurinol, accumulate. The dose should be reduced. Metformin is occasionally associated with increased risk of renal lactic acidosis. Avoid if your GFR is less than 30. So in conclusion, many drugs can cause kidney injury by a variety of mechanisms. When prescribed, ask, can this drug cause kidney injury? Is my patient at risk of adverse effects? Is there a safer alternative? Does the drug need dose modification? How will I monitor the patient for adverse effects? Thank you.
Thank you, Sagren. Thank you.